Good. So, hello everyone, my name is Thomas Model. I'm a recently appointed trustee to the LEB Club. Don't have a clinical background, but these two lovely ladies do, and they are experts in the field. So, just a quick reminder to please do put your phones on silent if you haven't done so. We're going to do about 40 minutes. You're already used to the format, but we're going to be waiting patiently for the knock on the door and startle everyone. And without saying too much more, I just want to introduce you both to Ali and Trudie. Thank you.
Yeah, so hi everyone. So lovely to see you all. So yeah, my name's Alison Hedley. I'm Medical and Professional Affairs Manager for America. And I'm here today with Trudie, my very good friend and co-presenter many a time. So
yeah, Ali and I are both nurses. I'm the Director of Education and Training for the Welsh Innovation Centre, and I'm also the Lead Tissue Viability Nurse for the Lindra Cancer Centre in Wales. So a very warm welcome. It's lovely to see you here in our workshop.
yeah, lovely. So today we're going to talk to you a little bit about skin cares in the lower limb, thinking a little bit about management and assessment of them. And we've got some nice interactive parts that we really hope that you'll take part in. I think if we look at the learning objectives that we want to cover today, it's very much about introducing you to the International Skin Care Advisory Panel, if this is an organisation that you haven't come across before. We'll look a little at skin structure in terms of those changes in elderly skin that predisposes a little bit to the vulnerability of this type of injury. A little bit about classification, one of the key things we'd really like you to be able to take away today. Assessment and management, a little bit about dressings and hearing a little bit from all of you and your experience, and then maybe specific considerations around the lower limb, which Trudie will take you through. So the first kind of thing I want to talk to you a little bit about is about ISAP, or the International Skin Care Advisory Panel. So is that something that you're familiar with? Some nods, some not so. Okay. So this is a really good resource for you, and I'll show you the website at the end of the session. But this was set up by two nurses in North America who were very passionate about skin cares because they recognised that this was a wound type that really wasn't assessed very well. It wasn't assessed with any sort of standardised approach. That there was very little about the management, it was very varied, and they set this organisation up and built to gain recognition in lots and lots of countries throughout the world. So they're very passionate nurses, and there are lots of resources, as I say, but there's also some great videos that are available for you to have a look at as well. So their concern was about that misdiagnosis and often undiagnosis, about the fact that you can result in serious implications and complications as a result. So when we look at the structure of the skin, this is just a little bit of a kind of overview. We know that the epidermis provides us with that protective structure. It is an avascular layer, it's relying on the blood supply from our dermis, and that dermis can be impacted upon by lots of comorbidities, can't it? Underlying causes that can impact on perfusion. Because this, when we look at the dermis, is kind of the powerhouse. This is where all those really important structures sit. And if we think about those elderly changes, this is when we might actually visually see those changes too. And then we have the subcutaneous layer, which provides protection, doesn't it, for those bony prominences. But if we look at what happens when we get older, we know that there is a 20% reduction in the dermis alone as we get to over 70. That there is a change with the ability for the epidermis and dermis to fix together. We know that the points that connect it get flatter and weaker, and therefore we're much more prone to shear forces. We know that certain disease processes like diabetes can impact on that microvascular circulation. So all of those elements leave us so much more vulnerable to the development of this type of wound, which was why the ISAP organisation felt it really deserved that recognition, to really be able to raise the profile and raise the awareness with nurses worldwide. But it's not just the elderly, it's often the other group that's very at risk is our neonates. You know, children that are born preterm, babies that are born preterm rather, their dermis in itself is completely underdeveloped by sometimes more than 50%. So handling is the big challenge with neonates. They need sleep, they need quiet and time in order to grow. So the less intrusion with handling, which makes it so very hard, isn't it, for families. But even the handling of healthcare professionals has to be at the minimum. And apart from their growth and development, it's also about the fragile nature of their skin. So if we look at skin tears in both the lower limb and the upper limb, you know, these can be very varied in how they present. So we can have something that's much larger, that may be not presented or managed immediately. So we can end up with tissue loss. Or we can have something that's, you know, still causing a lot of problems. We have these small hemorrhages and bleeds as a result of that change in the microvascularization of the skin, but also to do with medication as well that the patient may be on. And these were some of the common terminologies that ISTAT found when they were doing some research and a survey amongst nurses internationally. That they were coded within the documentation as tears or abrasions, which kind of makes them sound a bit superficial, doesn't it? Nothing really to worry about. But some of them were being coded or treated as if they were pressure ulcers. And that takes you down a completely different path, doesn't it? You know the difference with moisture lesions and pressure ulcers, how that takes you completely different ways. And also just the term of just a skin tear, again implying that this is really not anything we should be concerned with. And we shouldn't have risk reduction pathways or pathways that we use for treatment. So I think it's really important to think about what is our terminology in the care setting that we're in. How do we describe them? And are we all describing them in the same way? So with that in mind, we've just got a little interaction here for you. So yeah, so you're all talking around exactly the same thing. But I suppose definitions always guide us in a very shortened version, but always pick out the key words in a definition, because they'll really guide you in your practice as well. So I'm just going to pass over to Trudie now, who will tell us a little bit more about that classification that you were talking about. Oh, turn off the remote.
Need to press the button on the remote.
Just here? Oh.
No, on the remote.
I'm used to touchscreens.
I think it's behind the
It's
laptop.
behind the laptop.
Oh, there.
Quite subverted, fine.
Press any button, except the power one.
It's not working.
Don't turn it off.
No. Oh, are they okay?
Yeah, I'm pressing them.
No. Is there an okay on there? The middle? Yeah,
There we go, fine.
So,
There's not any button, it's the
Okay. Now, I'm glad to hear that some of you are already familiar with skin tears, but we're going to look at the categorisation of them in a moment here. But just looking at these three pictures here, to me this really does emphasise how complicated they are, how complex they are, and they're not just a small minor wound, are they? You know, you've lost an awful lot of your epidermis here, the same here. And again, if that wasn't treated correctly on the lower limb, would we end up with a chronic non-healing situation there? And then look at the surrounding skin here. Quite often, isn't it, we're not just looking at the tear, we're looking at the bruising. Yeah, we're looking at the fragility all around that area. So we're not talking a simple situation here. So there is a skin tear classification that some of you are aware of, but not like the pressure ulcer classification, this is simple. I find people still struggle where I work with all those 5 classifications in pressure ulcers. People still get confused. This I don't think is confusing at all. I think it's really simple and really helpful in clinical practice. So with type 1, I've had a flap, but I've been able to put the flap back. Yeah. So here, I've got no tissue loss whatsoever, type 1. Type 2, my flap, I can't get it right the way back. And we wouldn't stretch it. But here, we've left it, but we've still got partial tissue loss there. So we're category 2. Yeah. Here, no flap. We either can't put it back because it's necrosis or it wasn't there when we found the skin tear. Type 3. Okay? So, in this workshop, your skills improve in 1 minute. Okay? 1 minute, that's all it takes. What category is this? 3. Category is this? 3. Category is this? 1. Category is this? 2. Less than a minute. You know, that's pretty good, is it not? Pretty good. Okay. But again, on this one here, we also have a 3 as well. Because we don't often see them in isolation, do we? So where on the body do you think is the most common place to have a skin tear?
Arms.
Legs. Arms. Hands. You can only have one. You can have arms or you can have legs. Which one? Hands up for arms. Hands up for legs. Hands up for on the fence.
Probably quite even, isn't it?
Isn't it? I found this statistic really.
Blur.
Wow. Look at that. 80%. And it's because we use our arms more than we use any other part of our body, isn't it? Yeah. Manual handling, lifting, getting dressed, getting washed. Yeah, we use that one a lot, don't we? We use that one a lot. So let's look, we talked already about these intrinsic and extrinsic factors that put our patients at risk. And I think we put them here, visuals for you, but I'm sure this is, you know, we all know what that is. Do we not? Yeah. We know what they are. Yeah. We're going to have some of that soon. Yeah. But these 3 are, well, they're important, aren't they? How mobile is the individual? And we'll look at that in the risk reduction pathway afterwards. And look at this. How many times do people knock their legs on the feet of the wheelchairs? Yeah. And what Ali said generally about ageing skin. Yeah. Which I'm all too well aware of myself. But then we get extrinsic factors as well, don't we? So those internal things we can do something about, can't we? Smoking cessation, nutrition and hydration, some things we can help with, yeah? And then we've got these things, the extrinsic ones, that we can't often do something about it. We can't often stop the trauma. If it's a fall, you know, we can't necessarily prevent it. We do a falls risk assessment. Does everybody know about skin tears? Is everybody up to date with skin tears? Knowing what's happening with the skin as we age, knowing how to classify them, having a risk reduction pathway in place. Is everybody at the same point? Not always. Not always. We can do some things about that, and we'll look at that when we look at things specific to the lower leg, what we can do to make things better later on. But the healthcare setting, and Ali showed that, didn't he? We could be care of the elderly, it could be on an intensive neonatal unit. So you've got different healthcare settings that influence how much is going into your skin and how much potentially can damage your skin. So if we've got intrinsic factors and we've got extrinsic factors, the chances are we're going to have skin tears. So when we're doing our assessment of the patient and the environment, we need to assess these factors. Okay, so I'm just going to hand you back to Ali now.
Okay, on the top cause. Maybe here. Blood trauma we have here. This is daily living. Okay, any others?
Falls, I think.
Falls.
Patient transfer and handling.
Okay. Interesting, a bit varied. I did say to the group here at the front that it can be influenced by the environment you're in, isn't it? So you might think, you know, that, oh, this is all I see as a result of, and I understand that. But this is just showing you just a result of this ISTAT survey. So this was 2012.
Yeah.
So interesting, because I can remember carrying out training exercises years ago with nurses all around skin tears, and we talked about handling.
Yeah.
About handling as being predominantly the reason, jewellery, you know, all those sorts of things.
Yeah.
And it's quite interesting, you know, but then again there's instances like we were saying as well, that, you know, it's the coffee table in somebody's home, or, you know, something within their house, a table, a little coffee table, those sorts of things that once somebody's done it once, it's repeated, isn't it? And so you have to take the things away. I remember doing that in my mum and dad's house. It didn't go down very well. But yeah, hey,
Cat scratches.
yeah, yeah.
I think the other bit you mentioned earlier is about this being international. Because I think
Yes.
you guys, the last two groups both said they hope the dressing related one would be lowest.
Yes.
Yeah.
Second. Yeah. Yeah, absolutely. Because, like you say, definitely, Claire. Sometimes we don't. And also sometimes people are not aware of what's available. We've seen less and less interaction and training provided by companies with products, not to sell their product but to give you the education around how they can be used. So, you know, take advantage of the fact that you've got a captive group here. You know, talk to them specifically about skin tears. What would they recommend? You know, what pathways can they support you with to introduce if you don't have one already? So, you know, I think this is really important, but like you say, Claire, internationally they don't have maybe all that we have. So just thinking about that as a common injury, how common is it actually in your practice? So do you see skin tears weekly or monthly? So weekly, would you say? Yeah. Yeah. And you know, what sort of products do you use? Do you use a variety? So you tend to use silicone, yeah. So different like foams or contact layers, that sort of thing. Yeah.
No stories.
So we're lucky in that we've got a wide variety of products that we can use for this particular instance. But I think sometimes you find nuggets of information from other people when you're in settings like this, what's worked well for them, particularly if they've got a very strong pathway already established. So, you know, it's an opportunity networking as well, you know, to talk to other clinicians, isn't it, about what they do. But, you know, we can't wrap everyone in cotton wool, and unfortunately these things, these injuries occur, but we just need to be much more aware of that prevention option. And this is some of the assessment and management of skin tears recommended by ISAP. You know, it's about that initial treatment. What are we doing? What is in our pathway? If we haven't got one, we want to have one that will help us around a step-by-step approach, so that we'll be able to reapproximate that flap. You know, we're dressing choices at the end. You know, we're processing that and promoting that holistic view of our patient. You know, we're looking at how the skin tear and the surrounding skin looks and how it's presenting, how we would classify it. I think it's really important if you, I mean, we joke about it, but if it's the thing that you take away, it's fantastic, because that will start a train of events within your care setting where there will be a uniform approach to this. You know, something that is so simple to do, but has the minimise the complexity and actually leads to you all, you know, striving for the same goal. So the different goals of treatment we need to identify, and then those prevention strategies which we talk a lot about. So it's about that stopping the bleeding, you know, because of the medication patients are on, all of those things that can contribute to a hematoma forming. How are we going to get rid of that? You know, we need to consider that. How are we cleansing it and reapproximating the flap? Because for a lot of you, you're not seeing it immediately on injury. You know, when I was a practice nurse, I might see it by the by, they'd come in for something else and I'd noticed that, you know, they've been there 3 weeks. So sometimes you're having to clean up that area, look at if there is a hematoma, how you're going to evacuate that. Have you got the skill set? Do you need advice from someone else? What sort of debridement tools or equipment do you use? We need to make sure we avoid any further injury in how we're handling that wound. And whether or not, as I said, that flap is still viable. What can we do to promote it? During our assessment, are we looking to see if there's any changes in that flap? Because if it starts becoming very dusky, we can see straight away that the perfusion has altered, and that might be just due to the fact of that patient's comorbidity. Returning that, we might need to hydrate that flap in order to be able to do that, because of that different time that's presented to us. And now it's all clean and we've removed any clot underneath it, for example. We're now to try and ready to align it. It might be using damp gauze, it might be using a wet cotton bud, damp cotton bud, that sort of thing. something that's gentle enough to be able to return that, so that we again can make sure that our original classification is correct. And when we look at, you know, the extent to some of these, this is why when you look at that terminology that we spoke about, you know, just a skin tear, well, I think this is pretty traumatic, isn't it? And I think it's a very emotive picture. I think I can almost see that patient at the other end of that arm. I'm sure I've met her. I'm sure I've seen these. You know, it's a, so that's why it's not something that's very trivial or just a by the by. And all the things that we do on wound assessment are exactly the same. You know, all the things that we need to consider, that integrity, the signs and symptoms we talked about, and particularly of infection, and also edema, which is something that we're going to hear from Trudie. So I'm going to pass over to Trudie now to talk a little bit more about that lower limb.
So if we've got a pathway, or if we haven't got a pathway, there's something that we can do that's very simple. Okay, so this piece of work was a good piece of research. It was done outside the UK, but it's a very, very good piece of research. In wound care, so the research isn't robust, but this was. This was done by a lady called Karen Carville. And what she found is that in one group they applied a moisturiser twice a day, compared to once a day. And when they applied it twice a day, look at how many skin tears they prevented. Yeah. Now when people come into the acute hospital where I work, they tend to sometimes, the doctors think, I'm in bed, I'm a patient, you do. Yeah, does that, anyone else? Yeah, nodding their head. People can moisturise their own arms. Yeah? Maybe if they've got problems, some can't, maybe. But on the whole, I say most people can do that. Yeah? Or do that so we don't get folliculitis. Yeah? Yeah? So make sure that we are moisturising, and that's in your pathway for skin tears. Good preventative care. Okay? Not difficult to do. And then I said to you we're going to talk about the lower limb in particular. So a risk reduction programme. So for the skin and the lower limb, we use silicone. We use silicone dressings and silicone tape. Okay. We might use a retention bandage that doesn't require pins or clips. Yeah. That sticks to itself. We might be using other things to protect the skin. It could be a bandage, it could be a piece of equipment. Okay. What can we do about the general health? Well, if the patient's perhaps is diabetic and has got neuropathy and has got no feeling, we need to get advice, because that lack of feeling tends to be the foot. But it's called a stocking-like distribution, and it works its way from the toes right up to the knee. So again, very vulnerable legs there for skin tears, because they haven't got the protection there because they can't feel. We've talked about medication, what steroids do to your skin. What about medication that makes you drowsy, makes you fall? Let's look at that. Are they wearing their correct spectacles? When did they last have their eyes tested? Yeah, you need good vision to look for the hazards in the home or in the care environment. And we'll talk about that in a moment, because if there's edema there, edema is going to delay healing, regardless of the cause of the wound. Then if we look at mobility, we've got some things here. Well, we do that anyway, don't we, to keep our patients moving where we can. We make sure we use the right equipment, so the equipment is not causing problems. We'll do this for our patients, don't we? We assess for nutrition, hydration, falls routinely on admission now, so that's part of it there. This is important, isn't it? And how many of you will be wearing those tonight? Okay, this is important. Like Ali said, when they're in the parents' home, it's got to be light, you've got to be able to see. People talk about having round coffee tables, not square ones, so you haven't got the edges. Yeah, padding them around the edge, so that those trauma, potential trauma points have gone. And also, you mentioned it at the back, the lady at the back, you know, you can mitigate some things, but you might not be able to get rid of the animals if they're causing a problem. But you just have to be aware in your risk assessment that animals are part of it, don't you? Especially in the lower limb. They can't normally scratch too high, but unless they're on your knee, but normally the lower limb. So what do we say about managing the lower limb? Well, when we talk about compression, we tend to think of venous levels. But if you've got a wound caused on the lower limb by trauma, we still need compression. The only time we wouldn't apply compression is if any of these red flags were present. The National Wound Care Strategy says, until you've dealt with these or investigated them, we don't apply compression. So that's your first assessment on the lower limb. And the National Wound Care Strategy, as you can see, 2023, so we're talking very latest guidance there. But then what they do say, if you've no red flags, get them into compression. Don't wait to Doppler, get them into compression. Mild compression.
So if the patient's already in compression and they're diagnosed with a DVT, do you take them out?
Yes, initially until you've got your confirmed diagnosis.
Right.
Confirmed diagnosis. That would be the only thing you'd be checking in case it's a different
Does that
diagnosis.
same with infection? Because when I learned how to do compression many years ago, we were always told take them out compression if they've got infected legs.
If it's too painful,
yeah,
that's the reason. That's the reason. But we've got a great lymphedema service. They're going to be talking tomorrow afternoon in Wales, and they are absolutely ideal. And they say in cellulitis, as soon as they can compress, they'll compress. It's pain that stops it.
I mean, what we do is we reduce the compression if they're in a great deal of pain, because you take the compression away, then the whole lot just breaks.
Yeah, exactly. And never get it back on again. Yeah. So you need to have your diagnosis correct. The number of people we have come into our clinics, skin cancers. The diagnosis is not the most. You've got to get your diagnosis. But the minute, if they've got edema and they've got a skin tone on the lower limb, compress. No red flags, compress. Don't hang about, straight into it. Okay? And within 12 weeks then you do your Doppler and your full assessment. Okay? But we don't hang about, we get them straight in compression, because we know reducing that edema will help with the healing. But people think compression is just about venous leg ulcers. Well, it's not. Any edema of the lower limb. Okay. So what I'm going to do now is hand over to Ali, and she will just take us through a couple more slides and do the summary.
Yes.
Thank you, Ali.
Thank you. So some previous groups were talking a bit about the stereo strips, so we just wanted to sort of highlight that in consensus documents that were done quite a while ago now on care of the elderly skin from a dermatology point of view, stereo strips were a no-no. And that's simply because we get all sorts of manifestations of stereo strips, don't we? We get amazing shaped stars and all sorts of head injuries and all sorts of things. So best avoided. They're not going to help you. And as I said to you before, you know, if you want to explore new ways of managing skin tones with different dressings, do come and take advantage of what we've got.
It'd be nice for A&E to actually help and use
I know.
that.
Oh,
When it's
I know.
coming out of A&E like
I
that.
know.
Crazy amount that's used. I can't believe some of the amount that
Yeah.
gets onto one. So just in summary, before we finish, is to send you, if you want to take a photograph or to jot down the ISTAT website, and you'll find it really, really useful. Lots of resources, prevention, risk reduction programs in there for you to use. And I think it's all about you walking away today with a little bit more knowledge around that classification, around maybe looking at developing a risk reduction program within your care setting, and thinking about that prevention. How amazing is it a little pot of emollient can make such a difference to the number of incidents that you're seeing with pressure ulcers, and thinking that some things we can't avoid, but some things that we can, and thinking about that assessment and classification. And you know, teamwork's really important, how we're all communicating this wound type. Try and think about maybe networking with other colleagues and clinicians that are here today, and well, what do? You know, is there a good example that you could take away? Hey, we don't want to keep reinventing the wheel. You know, it's a really good opportunity, and as nurses we tend not to do a lot of that sharing, we tend to do what we do, but I think it's a really great opportunity that, you know, we can look at taking away that as well as your experience today. So thank you all very much for your contribution. Trudie and I are delighted, so yeah, so on to the next. I think it's one more before lunch.